Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we're exploring the role of GPs in fertility management. We also discuss how GPs can navigate ethical issues around fertility treatments and patient care. This podcast is sponsored by Genea Fertility. Genea has been helping create families for almost 4 decades. Their world-leading IVF science and technology delivers success rates consistently higher than the national average, ensuring your patients have the best chance of a healthy baby. Referral and patient resources can be found at genea.com.au. Associate Professor Alex Polyakov is the Medical Director of Genea Melbourne City. He's a highly skilled obstetrician, gynaecologist and fertility specialist based in East Melbourne and joins me now. What are the most significant updates in the clinical guidelines for infertility management that GPs should be aware of?
Well, one of the most significant changes that took place over the past 5 to 10 years is that, especially in Australia, we do not transfer more than one embryo at a time. And this is related to the fact that we try not to result in multiple pregnancies. We're trying to keep it to singleton pregnancies, mainly because multiple pregnancies obviously are much more complicated. And so at the moment in Australia, I would say that 98% of embryo transfers are single embryo transfers. Another change that took place over a slightly longer time period is that the majority of clinics, certainly in Victoria, all clinics have moved from transferring day 2 embryos to transferring day 5 embryos, or so-called blastocysts. And that improved the success rates per embryo transfer quite significantly. Another change is that there is a move towards using less intracytoplasmic sperm injection. So that is a technique that is used for male factor infertility, but in some countries it is used universally. And what is involved is that a single sperm is selected and physically placed inside an egg. And there are some evidence to suggest that if male factor infertility is not an issue and the semen analysis is completely normal, under those circumstances, the clinical outcomes are better if traditional IVF method of fertilization is used. And that involves just placing an egg and sperm in a dish for sort of natural sperm selection and fertilization overnight. The third change that I think is quite significant is that we produce a number of embryos from every IVF cycle. So there is one embryo usually that goes in, and then there are embryos that are frozen for future use. And so if the first embryo doesn't implant, frozen embryos can be used without women undergoing further stimulation and egg collection cycles. And there are a number of options as to how to transfer those frozen embryos. And if a woman has regular periods, it is now becoming clear that what's called the natural thaw cycle is probably the best in terms of neonatal outcomes. And what is involved in that is that we time embryo transfer to women's natural ovulation. The alternative is to use artificial cycle, where estrogen is initially given to thicken the endometrial lining, and then adding progesterone and then timing embryo transfer to the start of the progesterone supplementation. And that is sometimes necessary for women who do not ovulate naturally. But there are some significantly, robust evidence to suggest that in a natural cycle, perhaps the clinical outcomes are better, but also the neonatal future outcomes are also superior. And therefore, the move currently is to try to use natural cycle or natural ovulation in terms of timing an embryo transfer.
How can GPs stay up to date with the latest research and protocol changes in fertility care?
Well, I believe that the Medical Journal of Australia and the Journal of the College of the General Practice, they publish various summaries, and I've been involved in 3 or 4 over the past couple of years that discuss various advances in fertility and general obstetrics and gynecology. And I would think that unless someone has a specific interest in this area, that would probably be the best source of information for generalist GPs. Obviously, there are some people who are more interested in this than others and work specifically in women's health. And for them, there are a number of publications that are reputable and publish review articles. For example, there are 2 or 3 journals that we all read, and they often publish very good, up to date reviews. And those are Fertility and Sterility, Human Reproduction, and Human Reproduction Update. And specifically, Human Reproduction Update, it's extremely highly ranked journal which regularly publishes the most up to date reviews on fertility and infertility treatments.
What are the current best practices for diagnosing infertility, and how do they differ from earlier protocols?
It's an interesting question. I mean, there haven't been any major changes in the workup for infertility for single women or for couples. So for a female, you would want to do some hormone levels, which would include LH, FSH, estrogen, and progesterone. Some would argue that FSH at the beginning of the cycle, for example, day 2, FSH of some value in terms of evaluating ovarian reserve. My feeling is that it can be done at any stage of the cycle. Progesterone on day 21, provided that the cycle is 28 days, would also be useful because that could confirm ovulation. We would also look at other hormone levels which may affect ovulation and fertility. For example, thyroid function and prolactin levels are also of some value. One of the things that became standard, and I feel that GPs can easily order it, except interpreting it is a little bit tricky, is the anti-Müllerian hormone level. And that essentially assesses the ovarian reserve. If it is normal, then it is age related, and so depending on the age the level will be different, but if it is within the norm for the age, that is somewhat reassuring. We lately began to see a lot of women who come just for that test to their local doctor, and then interpreting it is a bit tricky in someone who is not actually trying to get pregnant, because it doesn't have a value for the future. It only assesses the situation as it is right now. And so it's impossible to say what the level will be in 2 or 3 years. I mean, it's reassuring if it's normal for someone who is young, but it doesn't mean that in 2 or 3 years it will not change. And so the value of the anti-Müllerian hormone testing is mostly for fertility treatment, for example, for people who are trying to get pregnant, to actually reassure them that their ovarian reserve is normal, and if it is not, to refer them to a fertility specialist for further evaluation. This also has some bearing on the latest advancement in egg freezing. So this is an area that I suspect a lot of GPs will be asked about: what age and at what stage of life egg freezing for future use would be of value. And it is a bit of a complex discussion, because we know that if women freeze their eggs early in their reproductive life, they're less likely to use them because they're much more likely to find a partner and have a family naturally. On the other hand, after about the age of 38 or 40, egg freezing is not really a viable strategy. And so there is a sort of golden middle somewhere around early to mid 30s, where if someone is not thinking about having children in the next 2 or 3 years, that would be the most important time to consider egg freezing at that stage. So I wouldn't recommend it for younger women. I also don't think it is a viable option for women over 40, but somewhere in early to mid 30s, I think that would be the best time. And in those circumstances, assessing ovarian reserve by doing anti-Müllerian hormone would be of some value. In terms of further testing, we always do pre-pregnancy screening bloods, so full blood count, blood group antibodies, hepatitis B, C, HIV, rubella, and varicella. And if someone is preparing for pregnancy, it's mostly relevant for rubella and varicella vaccination. They should be vaccinated if their titers are low. Further testing would depend a little on what the situation is. I mean, I think that a pelvic ultrasound should absolutely be a part of initial evaluation, because there are certainly cases where there might be intrauterine polyps or fibroids or cysts or endometriomas or something structural that may affect future prospects of falling pregnant. At the same time, an ultrasound can assess what's called antral follicle count, and it's a number of little follicles in the ovary, which correlates fairly well with anti-Müllerian hormone levels, and it gives you just another dimension on assessing ovarian reserve at a particular time. So those are the tests that I would suggest would be of value to be done by a GP before they refer someone for fertility assessment by a specialist. For males, it's actually more straightforward unless they have some sort of problem with the endocrine system or sexual performance. If everything is well from that side of things, a semen analysis and anti-sperm antibodies would be useful, and most GPs usually order that, except most don't order anti-sperm antibodies. And that is a significant shortcoming, I feel, because we have to reorder semen analysis to perform sperm antibody tests. And of course, that's not a test that is fully bulk billed, so patients are often out of pocket for two tests. If the test comes back normal and the antibodies are negative, and as I mentioned, sexual performance and endocrine profile is normal, then no further testing for male is required. On the other hand, if you have an abnormal semen analysis, once again, depending on how abnormal it is, I would usually suggest repeating the test in about 6 weeks to see if it's really abnormal, because the parameters in sperm are quite variable from day to day, from week to week, from month to month. And if any of the parameters are significantly or grossly abnormal, then a referral to a specialist fertility doctor would be appropriate at that stage. If it's mildly abnormal, then a repeat semen analysis after 6 to 8 weeks would probably be of benefit. So to summarize, if I lived in an ideal world, I would see patients who have all these tests done prior to coming to see me for fertility consultation, because I can have a look at the results and I can sort of start working out what the problem might be and what the treatment plan might be as well. The only thing I would say is that it might come a bit later in the podcast, but at what point do you order all these things? What is the definition of infertility? And I might touch on that now. The general consensus is that in women under 35, if they have regular periods and there are no other issues, 12 months of trying would give them about 80 to 90% chance of falling pregnant. And therefore, these evaluations should be done at the end of that period if the couple is not pregnant. On the other hand, if someone is a bit older, and we're talking about female age mostly because male age doesn't have as much impact on the prospect of future pregnancy. So female age over 35 or 38, you would probably start looking at various tests after about 6 months of trying, because their time is running out, so to speak. Time is not on their side, and 6 months of trying when there is a problem that cannot be corrected could actually affect their chances of falling pregnant with future treatments like IVF. And therefore, 6 months of trying in older couples would probably be sufficient to start those investigations and perhaps to consider referring to a fertility specialist at that time.
What research or techniques are on the horizon that might improve fertility outcomes in the next few years?
It's a tricky question. There are a number of things that are being looked at in terms of improving outcomes in IVF, especially in older women and women who have recurrent attempts without falling pregnant. And the list is very, very long, and new things come on the horizon all the time. At this point in time, I don't think there is anything that shows excessive promise, so to speak. I mean, poor responders for IVF, women who don't produce a lot of eggs or women who produce very poor quality eggs, unfortunately, there is nothing proven to improve the situation. There are a number of things that have been tried, such as corticosteroids, clexane, aspirin, and various other things, but none of them have been shown to be strongly associated with improved outcomes. I think there is a possibility that at some point in the next 5 to 10 years, we may be able to grow follicles grow eggs rather, from very small follicles. So stimulation may not be required. We may just get eggs that are not mature and mature them in the lab in vitro and then use them for IVF. And that is a very active area of research, but unfortunately, the results are somewhat variable. It's not easy to transition an immature egg into a mature one, which we can use for IVF purposes. But I think that that area of research probably shows the most promise out of all the things that are being looked at. I mean, there are always improvements in the labs, so people use various culture mediums and such, and also there is a lot of excitement about using artificial intelligence in the labs in terms of selecting embryos that may produce the highest pregnancy rate. So what happens is in a typical IVF cycle, you may end up with, let's say, 5 embryos that are of variable quality. And when I talk about the quality, I talk about how they look. So the best looking embryo is the best quality embryo, and it's pretty clear that those embryos have the highest potential to produce a pregnancy. But sometimes you have embryos that are very similar, and then the choice of which one to transfer first falls onto embryologists who sort of compare it on the looks only. But these days, in most labs, a device called embryoscope is employed. So embryos are cultured in a special machine which takes pictures of the embryo as it progresses through development. And so a lot of data are generated from that. And these data can be used with the help of artificial intelligence to work out which embryo at the end of the day will have the highest potential. And that, of course, if that was possible to achieve, to pick the embryo that has the highest chance of producing a pregnancy, that would obviously shorten the time of pregnancy for some people. And so that is an area that is being actively looked at. And to these models that determine which embryo is the best, you can also add other parameters such as paternal age, maternal age, and various other variables to improve the reliability of that model. But because there are so much data available for every embryo from that sort of movie on how it progresses, you must use artificial intelligence to achieve some sort of a result, and that is something that's being done currently, and a very exciting area of research.
Are there any recent changes in protocols for ART procedures that have improved success rates or patient experience?
Well, I think the introduction of embryoscopes, and they're these machines that take pictures of the embryos as they develop, has had a significant impact on patient experience, specifically because, for example, in our clinic, patients can actually log in via internet to look at how their embryos are developing, and that creates some sort of a bond, and patients really like it. It's an easy thing to do because the pictures are there. We just have patients access them remotely. The protocols, in terms of changes, nothing really major has taken place over the past perhaps 5 to 10 years. I mean, as I mentioned, we moved to single embryo transfer. We moved, or trying to move, to reducing the use of intracytoplasmic sperm injection if it's not necessary. We are trying to encourage our colleagues to do 4 cycles in a natural cycle, timing it to natural ovulation rather than artificial cycles. But in terms of experiences, I think that has been the biggest change. In terms of protocol, not particularly. The drug companies are making progress in making medications more user friendly. There is that. There are some drugs that can be taken once a week rather than every day. But those are minor tweaks with the injectable devices more than anything else. The protocols themselves haven't changed for a number of years. We mostly employ what's called uh, antagonist protocol, which involves a number of medications. I won't go into details, but they seem to be the safest option and the most effective option for most people. Additional benefit of those protocols is that you can use a special medication to achieve the final maturation of oocytes, which reduces the risk of ovarian hyperstimulation syndrome. And for those of you who are not familiar with ovarian hyperstimulation syndrome, or OHSS, it's a significant complication of ovarian stimulation in IVF, and it can be quite severe, especially for women who produce lots of eggs with high ovarian reserve. Some women can end up in hospital for weeks. And so we are trying very, very hard to reduce the rate of that complication. And these newer protocols with newer medication combinations actually achieve that. And so the safety of IVF process as a whole has improved quite significantly due to these changes.
I like that people can watch the embryos grow.
Yeah, the embryos grow. Yeah, so it's a incubator essentially. It's like any other incubator, but what it has a little camera over every dish that's inside, and the camera takes a picture every 5, 10, 20 minutes. And so what you end up with is a movie of an embryo from fertilization, and then it starts dividing and growing and produce and getting to day 5 blastocyst. So it's actually quite fascinating. People really like that.
I can imagine. And here's a final question. What role does evidence-based medicine play in shaping current infertility treatments? And how can GPs ensure that they are following best practices?
Well, evidence-based medicine plays a significant role, and the majority of fertility specialists try to use treatments that are evidence-based. Unfortunately, when things don't work, both patients and doctors look for things that may help. And those things, they're called IVF add-ons. There is a special name for them. They don't constitute the standard IVF cycle, but they're sometimes used for trying to improve the outcome, either the number of eggs that is collected or the quality of eggs. And those things that I'm thinking of are usually vitamins and minerals and various other add-ons. Acupuncture for IVF is another add-on. There are a number of medications, and it's a very long list, that have been used in attempts to improve the outcomes, clinical outcomes in IVF. Unfortunately, none of them have been shown to do what they're supposed to do as yet. But this is an active area of research. Some fertility specialists use these add-ons more liberally than others. And I suppose the advice that I would give to GPs is to look at how the IVF cycles are run. If someone uses a lot of add-ons that are not evidence-based, they're probably not doing the best they could. So those things can be used and should be used under certain circumstances, but quite selectively. And if they're used universally, then that is not really evidence-based practice. And so I would say it's the responsibility of the GPs when they refer the patients to find out what kind of outlook a fertility specialist has on these add-ons that may not be of benefit and in some cases can actually be harmful.
Thank you to my special guest, Associate Professor Alex Polyakov. This podcast is sponsored by Genea Fertility. Genea has been helping create families for almost 4 decades. The world-leading IVF science and technology delivers success rates consistently higher than the national average, ensuring your patients have the best chance of a healthy baby. Referral and patient resources can be found at genea.com.au. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thanks so much for listening.